Good afternoon. In this, my topic is preparation and management of tube feeding for a cirrhosis patient. In general, we have discussed what is enteral nutrition, what are the indications and contraindications. No, ma'am. What are the indications and contraindications of enteral nutrition? What are the advantages of enteral nutrition? And what are do's and don't management and preparation for cirrhosis patient? First is enteral nutrition. Enteral nutrition is the preferred way of delivering nutritional support for patients who have a functioning GI tract, gastrointestinal tract, but cannot ingest enough nutritional orally. The indications are decreased appetite, 5 to 7 days of inadequate intake, inability to feed, maybe some neurological problem or physical, increased nutritional requirement, prolonged anorexia, obstruction of esophagus and oropharynx, impaired gastric emptying, GOO matlab means gastric outlet obstruction, and gastroparesis, and esophageal motility and dysmobility. And what are the contraindications? Intestinal obstruction, intestinal perforation, inability to assess the gut, severe acute pancreatitis, and high output proximal fistula shock, and severe gastric reflux. These are the contraindications जिसमें हम enteral nutrition provide नहीं कर सकते. Now next is route of enteral nutrition. These are the routes. Nasogastric. This feed tube passes from the nose down to throat and esophagus and ends in the stomach. And nasojejunal, जिसे हम NJ tube बोलते हैं, कि this feeding tube passes through the nose, throat, esophagus, and continue through the stomach and the first section of the small intestine. And percutaneous endoscopic gastrectomy, जिसे हम PEG बोलते हैं, this feeding tube is inserted directly into the stomach. And jejunostomy feed is inserted into the jejunum, the middle section of the small intestine. Now, this is the type of tube. मेनली जो भी पेशेंट है जिनकी जितनी रिक्वायरमेंट होती है, कौन सा हम ट्यूब प्लेस करें, कितने गेज का होना चाहिए, हम वो ट्यूब यूज करते हैं फॉर एंट्रल न्यूट्रिशन में. नाउ नेक्स्ट इज प्रिंसिपल ऑफ एंट्रल न्यूट्रिशन. प्रिंसिपल क्या क्या होते हैं एंट्रल न्यूट्रिशन के? टू मेंटेन द बॉडी वेट, टू अचीव द न्यूट्रिशनल असेसमेंट, टू मेंटेन एंड इंक्रीज द मसल मास. What are the thumb rule of enteral nutrition? हमारा जो स्टैंडर्ड फॉर्मूला होता है enteral nutrition का, वो क्या है? 1 किलो कैलोरी पर ml calorie density, and protein is 35 to 40 gram per liter protein, and average osmolarity is 300 to 500 osmol per liter. And enteral formula with high calorie is 1.5 to 2 kilocalorie per ml calorie density and 40 to 45 gram per liter protein. And this average osmolarity is 600 to 700 osmol per liter. Now, next is types of nutrition. These are the nutrition support: oral, enteral, and parenteral. What are the advantages? Preserves gut integrity, easy to insert, better tolerated by patient, and can aspirate. It is also very important, can aspirate the gastric content and assess the residual volume, and less costly than TPN, and improved gut mucosal health, improved systemic immune system, and more convenient than parenteral nutrition. Now, next is parenteral versus enteral nutrition. Parenteral nutrition is basically feeding through the central vein and feeding through the peripheral vein. Enteral nutrition already discussed in previous slide. Sorry. This is the guidelines for liver disease in 2020. जो पेशेंट जो लिवर सिरोसिस के जो पेशेंट होते हैं, दोज हु हैव माल न्यूट्रिशन रिस्क, जिन्हें सबसे ज्यादा होता है इन सिरोटिक पेशेंट, who cannot be fed orally or who do not reach the nutritional target through the oral diet, then enteral nutrition should be performed. And esophageal, agar varices hain esophageal, are no absolute contradiction for position and nasogastric tube. This is the nutritional recommendation for liver cirrhosis. Nutrition requirement is energy is 35 to 40 kilocalorie per kg ideal body weight per day. Protein is 1.2 to 1.5 gram per kg ideal body weight per day. Feeding route is oral nutrition supplement and tube feeding. The outcomes are enteral nutrition, improve nutritional status, liver function, reduce complications, and prolong survive in cirrhotic patients. This is the type of enteral nutrition: nasogastric, nasojejunal, and PEG, gastrictomy and jejunostomy. Nasogastric is, I've told you, nose to stomach. Nasojejunal is nose to jejunum, and PEG is stomach through the abdominal wall. This is cheap, easy to insert. Residual volume can be assessed easily, and disadvantages: uncomfortable, easily dislocated, tube dislocate हो जाती है easily, and increase aspiration risk. Aspiration risk को बढ़ा देता है. And nasojejunal is decreased risk of aspiration. Indications are gastric reflex, delayed gastric emptying, and disadvantages: not easy to place, damage to gastric mucosa, and impaired absorptions. And PEG is contraindications are gastric ulcer, gastric अगर कार्सिनोमा का पेशेंट है या एसाइटिस है या गैस्ट्रिक अल्सर्स है, तो दीज आर द कॉन्ट्राइंडिकेशन, हम उन्हें पेग प्लेस नहीं कर सकते हैं. एंड कॉम्प्लिकेशंस आर सेप्सिस अराउंड पेग साइट and intra-abdominal wall abscess and persistent gastric fistula. And gastrectomy is already told to insert in the tube either surgical or by percutaneous endoscopic procedure into the stomach. And jejunostomy is also insertion of a tube directly into the jejunum, either surgical or percutaneous endoscopic procedure के through ये jejunostomy procedure होता है. Now next is regimens for enteral feeding: continuous feeding, intermittent feeding, and bolus. Continuous feeding is given 24-hourly continuous without interruption, and intermittent feeding is given over 24 hours period with intervals of rest, maybe of 3 hours feeding or 2 hours rest. मतलब 3 घंटे चलाएंगे फिर 2 hours हम hold करेंगे. Then bolus feed is a major amount is given by syringe over identified time period, maybe of 300 3 hourly, 300 2 hourly. That is bolus feed. This is the most important कि RT feed में हम क्या-क्या instruction, safe handling of RT feed, rate and method of delivery, मतलब wash hand and use clean equipment, refrigerate unused portion in clean closed containers, hang time for prepared feed not to be more than 4 hours, and rate and method of delivery. Initiation the feed हम 50 ml per hourly to see the first patient tolerance, मतलब 50 ml से start करेंगे, उसके patient की tolerance देखेंगे, then start with 50 ml and followed by 100. Gradually, धीरे धीरे हम feed को बढ़ाएंगे 100 ml, then 150 ml, and then finally 200 to 250 ml too early, which is full strength of feed according to the patient condition or tolerance. And फिर उसके बाद हम increase quantity, मतलब feed की quantity को हम increase कर सकते हैं. Bolus भी start कर सकते हैं 250 ml to 300 ml per 3 hourly, और हर फीड के बाद आपको फ्लश ट्यूब विद वाटर 50 ml, हर फीड के बाद आपको 50 ml वाटर से ट्यूब को फ्लश करना है, मतलब साफ करना है. रेगुलर फ्लशिंग इज द की टू सक्सेस. नाउ GRV, gastric residual volume. Check gastric residual volume GRV every 3 to 4 hours. check aspirate after each feed. If it is more than 50 ml, then hold next feed and decrease the volume or increase interval of feed. अगर 50 ml से ज्यादा आ रहा है तो आप जो उसके बाद की नेक्स्ट फीड आप होल्ड कर देंगे. अगर उससे ज्यादा एस्पिरेट हो रहा है, 50 is more than 50 ml, and elevate the head of the bed is 30-degree angle during feed. Always use boiled water to make consistency proper, and stop feeding 30 minutes to 1 hour before chest physiotherapy. अगर चेस्ट फिजियोथेरेपी हो रही है किसी भी पेशेंट की, तो आपको 30 या 1 आवर्स के बाद फीडिंग को स्टॉप कर देना चाहिए. In case of loose stool or diarrhea or and uncontrolled sugar, then continuous feed should be given. These are the tube feeding steps. First, wash your hand before and preparing the feed. Second is पेशेंट का जो हेड है वो एलिवेट करके इन 30 डिग्री एंगल पे एलिवेट करके रखना है. थर्ड स्टेप इज स्टेरिलाइज द सिरिंज. जो भी आप सिरिंज यूज कर रहे हैं फीड देने के लिए उसको स्टेरिलाइज करना है. एंड फोर्थ स्टेप इज फीड देने का जो तरीका होता है, जैसे फीड आप होल्ड कर रहे हैं और जो पाइप कनेक्ट, जो ट्यूब आप कनेक्ट कर रहे हो उसको आपको होल्ड करना है, मतलब उसको वहां से प्रेस करके रखना है, फिर फीड डालना है, जिससे कि आपको मेजरमेंट भी पता चल सके और उसमें कोई भी गैस या बबल्स ना आ सके. नेक्स्ट, पेशेंट लाई डाउन टू आफ्टर 30 मिनट्स, मतलब आप फिर पोजीशन को पेशेंट को पोजीशन पे लिटा सकते हैं आफ्टर 30 मिनट्स बाद. व्हाट आर द ट्रबल शूटिंग वाइल ट्यूब फीडिंग? फर्स्ट, ट्यूब माइग्रेशन. ट्यूब जो है वो डिसलोकेट हो जाती है. GERD, गैस्ट्रिक इसोफेजियल रिफ्लेक्स डिजीज, ओवरफीडिंग, कॉन्स्टिपेशन, ऑब्स्ट्रक्शन एंड इंटरकरेंट इलनेस, मतलब कोई भी इलनेस हो वहां पे. दीज आर द ट्रबल शूटर. What are the complications of enteral nutrition? Maybe digestive complications हो सकते हैं, mechanical complications, infective complications and metabolic complications. Digestive complications may be patient having उसको vomiting हो सकता है, regurgitation, मतलब food जो है वो वापस reflex हो सकता है, constipation, diarrhea and abdominal distension. Mechanical complication is tube obstruction, malabsorption, perforation of the intestinal tract, and leakage and bleeding from intestine, site erosion, and ulceration and necrosis of skin and mucosa. And infective complications are infection of the tube insertion site and aspiration pneumonia, nasopharyngeal and ear infections, infective diarrhea. These are the complications of enteral nutrition. And metabolic में electrolyte हमारा disbalance हो सकता है, hyper and hypoglycemia, vitamin and trace element deficiency, and maybe of refeeding syndrome. It means tube feeding syndrome. What are the do's and don'ts? क्या हमें करना है, क्या नहीं करना है? अगर if patient diarrhea अगर है उसको, तो determine first cause of diarrhea and check for underlying medical, मतलब उसकी क्या क्या medical conditions है उससे check करना है. उसकी osmolarity of formula जो आप feed दे रहे हो उसकी osmolarity कितनी है, patient कितना tolerate कर रहा है, उसकी intolerance to osmolarity of formula, bacterial contamination of tubes, and continue to feed at a lower rate. अगर vomiting or nausea, don't dilute the patient formula. This reduces nutritional intake and can introduce bacteria. अगर vomiting है, nausea है, तो reassess the tube regimen. मतलब ट्यूब जो है, जो प्लेस है वो सही जगह प्लेस है कि नहीं है, इसे हमें चेक करना चाहिए. एंड मेंटेन प्रॉपर फीडिंग रेट. And don't ignore existing medical conditions that may impair gastric emptying. Dehydration, make sure the patient receives the volume of formula prescribed, and check if free water flushes are regularly done. and don't continue use of formula with a high renal solute load. Refeeding syndrome, ensure feeding begins slowly and monitor weight, metabolic indicators, add calories slowly as tolerated by the patient. Don't overfeed a malnourished. जो भी patient, जो malnourished patient होते हैं, उन्हें हमें बहुत ओवरफीड, मतलब बहुत तेज स्पीड में फीड को नहीं चलाना चाहिए. रीफीडिंग सिंड्रोम के चांसेस हो सकते हैं. Maintain tube clogging, flush tube with 10 to 30 ml of warm water every 4 to 6 hours during intermittent feeding or continuous feeding. Administer solid medications for crushing through thoroughly and dissolving in water before putting in tube. हर ट्यूब से आप जो भी सिरिंज से आप जो भी मेडिसिन दे रहे हैं, उसके बाद आपको 50 ml वाटर से ट्यूब को फ्लश करना है, उसको साफ करना है. ठीक है. डोंट फोर्स फ्लूइड डाउन ट्यूब, मतलब आपको फोर्सली नहीं ट्यूब देना है. हमेशा होल्ड करके उसमें आप फोर्स नहीं करेंगे, वो अपना ग्रेविटी के साथ वो इजिली ट्यूब जो आप फीड दे रहे हो वो इजिली पास हो जाएगा. Then what are the approaches to nutritional support? Pre-treatment is nutrition screening, history of weight loss, physical examination, हमें उनका BMI check करना है, and lab studies main for serum albumin. अगर patient malnourished है, then तब आप उनको oral supplement दे सकते हैं. अगर moderate and severe malnourished है, then aggressive nutritional support. If GI tract is functional, if yes, then go for oral supplement and enteral tube, and if GI tract is non-functioning, then go for parenteral nutrition. These are the solutions of nutritional management. अगर पेशेंट की डेफिशिएंसी को प्रिवेंट करने के लिए, उसके वेट लॉस को मिनिमाइज करने के लिए हम उसकी चॉइस के अनुसार उससे पहले न्यूट्रिशनल काउंसलिंग करेंगे, फिर then switch for solid food, then switch for semi solid food, liquid food, then अगर patient इतना convenient है, then go for nasogastric feed, nasojejunal gastrectomy and TPN. These are the protocol for monitoring guidelines: clinical, biochemical and nutritional. First, sign and symptoms of edema, glucose monitoring. If patient is diabetic or without diabetic, आपको डेली चेक करना है. इन क्लिनिकल एंड बायोकेमिकल इंटेक, उसका इंटेक कितना है, आउटपुट कितना है, ये डेली चेक करना है. उसका सीरम इलेक्ट्रोलाइट, ब्लड यूरिया, नाइट्रोजन, क्रिएटिनिन, ये आपको देखना है, चेक करना है. एंड नाइट्रोजन बैलेंस फ्रीक्वेंसी इज वीकली इफ अप्रोप्रिएट. एंड न्यूट्रिशनल मैनेजमेंट इज वेट मॉनिटरिंग, डिहाइड्रेशन फ्रीक्वेंसी, एब्डोमिनल एग्जामिनेशन. हमें abdominal examination भी करना है. if abdominal is soft, firm and distended, मतलब ये हमें डेली उसका चेक करते रहना है, तभी उसके बाद फीड डिसाइड कर सकते हैं. ऐसे नहीं है कि अगर abdominal distension है तो आप फीड कंटिन्यू देते जा रहे हैं, ऐसे नहीं करना है आप लोग को. Then home care consideration is teach patient and family correct techniques for administration of tube feeding. Sign and symptoms of potential complications. Need to assess tube placement and residual before each feeding for gastric feeding only. And principle of medical aspects including careful hand washing, refrigeration of formula, and cleaning of equipment with soap and water, and through dyeing between feedings. This is the some tube feed for hospital patient. Generally, we are using this. This is the composition of churn diet, जिसमें हम जो हमारा रोटी, दाल, सब्जी है, उसको हम churn form में देते हैं. These are the recipes for the tube feed. First is churn diet. Second, milk with roti into 50 ml. कितना उसमें energy, protein, fat, carbs and sodium, potassium उसमें जा रहा है. Next is high protein, and next one is curd with roti. Thank you.
You have covered very well. One thing I got to add that patients with alcoholic liver disease, patients with alcoholic hepatitis, nutrition is a therapy.
Yes, sir.
Nutrition is the first line therapy treatment to them. So in those cases, even the patient is not malnutrition, BMI is normal. Even then, we advise for it, high calorie diet.
Yes, sir.
So can you suggest some calorie dense foods for such situation where the patient is not able to tolerate, but we need to give in the less volume but high calorie dense?
Yes, sir.
Is there any formula or thing we can
Sir, HP, high protein diet, sir.
So the pain, if the condition, the volume is the situation to control the volume, and patient is not able to tolerate that much of dense feed. So we need to add on MCT. That is the only thing that we can make the we can add. Yes sir, जैसे कि मैडम ने बोला कि कैलोरी हम 1 कैलोरी पर ml, तो it means कि आपने कहा कि कैलोरी चेंज करना है, it's 1.5 to 2 किलो कैलोरी पर ml है। तो जैसे कि एक रेसिपी है हाई प्रोटीन रेसिपी, 150 ग्राम ऑफ हाई प्रोटीन रेसिपी गिव्स टू 250 कैलोरीज। तो हम ऐसी रेसिपीज काम कर सकते हैं, जैसे बहुत छोटा सा एग्जांपल है कि अगर हम 100 ग्राम दही लेते हैं तो इट गिव्स 70 कैलोरीज, बट एट द टाइम ऑफ कर्लिंग जब हम उसमें एक्स्ट्रा मिल्क पाउडर ऐड कर देते हैं और उसके साथ में कुछ और प्रोडक्ट्स ऐड करते हैं, जैसे कि हमने क्लीन दूध लिया, दूध में हम दलिया बना देंगे तो वो कैलोरी डेंस हो जाएगी। इट्स नॉट दैट वी कैन ऐड द शुगर, अदरवाइज फॉर द कैलोरी डेंस वी कैन ऐड द ऑयल, सो कैलोरी विल बी dense by using the sugar and fat also, then calorie will be completed at least 2 kilocalorie per hour. High protein is a very good example for this. We are using for the hospitalized patients also. We are using 2 to 3 feeds per day for this.
Even with this, you can further add on some things like you can add some eggs, some other protein bombs. So, but that will increase the concentration of this. That may be having some problem. But if patient is tolerant to it, you can add further things into this separate recipe.
Sir, this is the thumb rule. To supposedly this is हमने एक बार कहा कि हमने अगर artificial pick किया, तो they will create the 1800 ml with 18,000 calories. But if we require only 500 calories, we will add the oil, we will add the more calories. लेकिन हम स्टैंडर्ड जैसे आप किसी चीज को स्टैंडर्डाइज करेंगे और अकॉर्डिंग टू द डिजीज स्टैंडर्ड वी आर मॉडिफाइंग
Please standard formula is
for
adds,
yes,
you can add yourself, or you can ask the people this give it specific formula.
Yes sir, most of the time for the reason if they are admitted in the dialysis unit, they require 800 ml to 1000 ml and required like 2000 ml. On that time we are using the oil right, if not we are using the sugar, so we are doing this. Yes sir, this is a very specific formula. We are doing it on personal. Yes sir, we are using. Sometimes we are taking the help of formula feed also.
Yeah, that has been done again. Like all the patients, suppose they are taking this in the hospital, they add 2 or 3 spoons of protein powder in that.
Yes.
We can tolerate that one, that continues.
Yes. It's totally individual.
Madam, your take was a very good question. Like I had 2-3 problems. You said that acute severe hepatitis and high output fistula are contraindicated to enter. Like it is for all those patients who are sick. Enteral nutrition or nutrition is not only like you should not be considered as nutrition; it's a part of therapy. All these patients require, in fact, very high volume and energy to like protein for the maintenance and to meet that catabolic requirement of the patient. If the bowel is adapting, taking those things well and not having any problem, there is no any problems, there is no contraindication for it.
Okay.
You might have to change the composition, like patient is having high output fistula.
Yes.
You might have to give like altered nutrition for those patients. Otherwise, you will not. It is not a contraindication. Secondly, intermittent feeding, like you have to like know that what is the difference between gastric and jejunal feeding. For stomach, it's a capacity organ. where you can give a bonus fee.
Yes.
300, 400. And but you want that to clear out in certain time. In case it is not clearing, then you have to, that is why you aspirate independently and check whether there is any revenue or not. You mentioned that it is 50 ml, 50 ml is nothing for us now. Like actually, what we recommend is if it is more than 150 or 200 ml, then only you stop. Otherwise, 50 ml is nothing, you can continue with the feed.
Okay. Okay, sir. Thank you.
Thank you, Ashish sir, for the insight. But I would add on that after the gastric, it can.
And we are buying, which is being secreted, that will automatically come to that for that cost.
Therefore, we actually are giving money. Therefore, we are giving by judgment.
It is jejunoscopy. Actually, nasofageal feeding is what? It is giving nutrition to the jejunum.
Yes.
It has a small caliber. That is why you cannot give a bolus feed. It's a small tube. So their preferences like to give a continuous feed, small volume, like 100 ml per hour. It will be a continuous feed, so that bowel will not disconnect. Patient will not be having any discomfort. This can be given through the nasofageal feed, through the tube, percutaneously passed into the jejunum, or operatively placed into the jejunum percutaneously. So that is actually same. And the problems with all those things are like if we are going for surgery for any other reason, if we have placed jejunum, that is okay. Otherwise, just to put a tube, we do not operate these patients unless until like there is proximal obstruction, this tube cannot be passed. But the problem with nasojejunal or nasogastric tube is it has continuously there into the nasopharynx. So problems with pharyngitis, leaky and block,
Mouth cancer,
and otitis media, these all things are real possibilities. So if we consider that this patient will require long-term feeding, people consider PEG, percutaneously placed gastroscopy, or percutaneously placed jejunoscopy, operatively or anything, or endoscopy.
Okay. Thank you, sir. Thank you.
Thank you. Now I would like to call upon Ms. Rita Anand to talk on nutritional management in short bowel syndrome and high fistula output.
Thank you. So there is no thumb rule or specific guidelines for short bowel syndrome or high fistula output. And there is no guidelines on nutrition. So it is all individual and depending on the remaining gut, which is functional and which is having the absorptive area. So what is short bowel syndrome? Reduction in functioning gut mass below the minimum necessary for absorption of nutrients and or water and electrolyte for leading a normal life because of less absorptive area. Short bowel syndrome typically arises after surgeries to remove damaged, diseased intestine. Greatest consequences of short bowel syndrome of malnutrition, dehydration, diarrhea, and weight loss. So the nutritional management for short bowel syndrome specifically depend on the remaining gut, remaining small intestine. So there is 3 types of short bowel syndrome. One is jejunostomy, another is jejunocolic. This is the remaining part that indicates the type. So jejunocolic. Again, so what is the etiology for short bowel syndrome? Blocked or restricted blood flow to the small intestine, Crohn's disease, perforated bowel, and this intestinal hernia, radiation therapy, injury, congenital defects, gastrointestinal cancers, twisting and tangling of small intestine, then necrotizing of enterocolitis, then other rare diseases. The physiological consequences. What are the physiological consequences? Increased gastric inputting, increased short this bowel transit time, increased gastric secretions in after first 2 weeks of surgery. Then resection of ileal and colic breakdown, that breaking the mechanism of absorption and digestion, changes in GI hormones, stoma leakage, steatorrhea and diarrhea, frequent gas, bag inputting, social issues. Nutritional consequences are because of short bowel syndrome are mainly dehydration, vitamins and mineral deficiency, electrolyte imbalance or deficiency, too much lactic acid in the bloodstream. Fatty stools, that is known as steatorrhea, kidney stones because of high absorption of this some of the macronutrient, too much stomach acid, then all these leads to weight loss and malnutrition. So how to implement your dietary prescription to the short bowel syndrome patient? So interventions are, step 1 is add salts to the meal, because they are electrolyte imbalance mainly because of high stoma output are this less absorptive area. So diarrhea, steatorrhea is there. Fluid absorption is very less. Water absorbs mainly in the small intestine. So that cannot hold the electrolytes. So salt, this hyponatremia and hypokalemia, then other nutrients are, the other micronutrients are depleted. So we must add salt to the meal, depending on the serum levels of the sodium. Low fiber diet, so that the diarrhea may not persist and the bowel can be functionally. Restrict the hypotonic fluids, that if we do allow the patient hypotonic fluids, that again increases the osmolarity and less of the water absorption. So restrict the hypotonic fluids up to 1 liter per day. Then rational, again, we should consider the sodium intake and fiber, soluble and insoluble fiber, avoid drawing water. Why? To restrict these parameters to sodium, fiber, and hypotonic solutions. Stage 2, establish oral intake. Restricted oral fluid to 500 ml, so that we can control the high fistula output. So we have to restrict the hypotonic solutions, water, tea, coffee, squash, alcohol, and hypertonic. Sorry, we have to allow the patient hypotonic solutions which has low osmolarity, that are tea, coconut water, squash, coffee. And we should restrict the volume of the hypertonic fluids, that are juices, cola, sips, and others. Drink a glucose saline solution. If we are not able to maintain the hydration level, so you can allow your patient to drink glucose saline up to 500 ml per day. Management of jejunostomy or high fistula output. How to handle salt and water depletion. Here you can say that there is one magical solution, that is ORS, or 1 glass solution. So ORS, just whenever you are allowing your patient you are asking कि ORS लेना है, so you must teach your patient कि 1 liter वाला है तो 1 liter पानी में ही dissolve करना. Many a times I find in my ward even, so अगर वो अपनी मर्जी से, या उनको लगा कि हमें डायरिया हो रहा है और फिस्टुला हाई आउटपुट है, या उन्होंने डॉक्टर्स को या डिस्कस करते सुना, सो वो जस्ट ORS लेना स्टार्ट कर लेते हैं. तो उनको यही नहीं पता है कि 200 ml वाला 1000 ml में उन्होंने डिसॉल्व कर लिया, या 1000 ml वाला 200 में. सो द ऑस्मोलरिटी चेंजेस, सो एब्जॉर्प्शन इज लेस, and sodium, potassium, hyponatremia and hypokalemia is there, and hydration may not be maintained. So we should teach our patient about this magical solution, that is ORS. Salt and water depletion correction include other causes of high output, like along with the high fistula output, we should consider the weather. If patient is at home or at in the ward, those respiration and perspiration along with the if it is summer, so we should ask our patient कि fistula output इतना है, so आपका daily requirement के हिसाब से 500 या 800 ml आपको ऐसे maintain करना है, plus आपको 200 ml और sips में लेना है. So IVF, this is intravenous fluid can be taken care, and we should calculate how much is given to the patient by IV fluid. So 2 to 4 liters per day, and even then the urine volume is less than 800, we should again consider and discuss to the treating team, treating consultant कि हमें और कितना पानी बढ़ा सकते हैं कि पेशेंट का जो यूरिन वाला बैग है उसमें इतना कम वॉल्यूम आ रहा है. मैग्नीशियम एंड पोटेशियम सप्लीमेंट्स occasionally, because these are the micronutrients that are absorbed in small intestine. So usually we can see the serum levels of magnesium or potassium are very low. So we should consider and we should allow our patient high potassium and high magnesium food and fruits to the patients. Restrict oral intake up to 500 ml if the fistula output is high. So we should restrict this much of volume of fluid per day, and we should ask and teach our patient कि वो gradual ही sips में लेना है. And again we should ask our doctor or residents कि इनका 500 ml से तो काम नहीं चलेगा. So other what measures can be taken? So वो IV से देने के लिए डिस्कस करना है. Hypotonic solutions like tea, coffee, juices, alcohol, coconut water, lemon water need to be considered and can be allowed to the patient if the fistula output is at normal up to 1000 ml. So hypertonic solution need to be restricted. ORS and 1 glass solution, like earlier I have told you, solids and liquids separately, so that may not increase the mortality and the fistula output. Taking care of oral nutrition, carbohydrate types, gradual increase in fat, we should consider the carbohydrate types majorly. If the patient is having the high fistula output, we should not ask the kid to take the complex carbohydrate. That increases bulk, and again, that will lead to the diarrhea and high fistula output. So very judgmentally, we have to decide what kind of carbohydrate we should ask the patient. If we are asking them कि हमें refined flour लेना है, so that water and this stool can be bind. But again क्या होता है, फिर obstruction के chances बढ़ जाते हैं. So very mindfully we have to decide according to the fistula output type कि consistency बहुत fluid है, liquid है या semi solid kind of है. So according to that bulk of the fistula output, we should decide the carbohydrate type. Refined रखना है या complex रखना है या दोनों का हमें mix करना है. Gradual increase in fat so that calorie density can be increased. Reduce the osmolarity for better absorption. Stoma output not altered. Then we have to add on the elemental diet, which are partially digested and can be absorbed easily. Probiotic and glutamine can be added for the better outcome, and as in anti-inflammatory, as in we can ask the patient to take this omega-3 and 6. Special concern, as usual, had been discussed, the ratio for total calories should not be less than 60% from the carbohydrate, fat 20%, protein again 20 to 30% can be, depending on the serum level of serum albumin and other weight loss history and all this. So protein should be of high biological value so that it can get absorbed, and biological availability of the protein should be high. So implementation of diet should be in oral sips and feeds. Enteral feeds should be allowed at night so that the prolonged fasting time can be covered, and we can increase the protein as well as the total calorie intake. Oxalate intake need to be reduced as 25 to 30% have renal stones. As the oxalate intake increases, absorption increases in the colonic area. So I would ask in the last to Ashish sir ki add on the oxalate intake so that more clarity we can have. Otherwise, oxalate rich food need to be restricted as these patients has high history of renal stones. So these are the trace vitamins and trace animal which need to be considered and need to be supplemented as in the given doses. Even if the condition is not improving, still the stoma output is high and weight gain is not appropriate, we should consider the PN. Point to be considered while handling nutrition for short bowel and high stomach output. 7 to 8, at least 7 to 8 small frequent meals to be allowed. Chew well and rarely feel the goodness of the food, so that patient may not eat the food in hurry. As the patient gets the food, you should ask na कि धीरे धीरे चबा के खाना है, टाइम देना है, इसको काम खत्म करने जैसा नहीं खाना है. Complex carbohydrates need to be included, like pasta, rice, potatoes, bread. These holds the water as well as the create the volume. So the stomach output consistency can be increased towards the semi-solid to solid. And protein should be of high biological value. Fat, limit fat up to 20 to 30%, but it should be including the essential fatty acid in form of soybean, flaxseed oil, sunflower. Plenty of fluid, consider ORS, 1 glass solution and ORS. Salt should be added in if the jejunum is not available. In jejunocolic patient only, we should consider the high salt intake, but we should take consideration of if the patient is hypertensive, and consider the serum sodium level also. Oxalate limit. Oxalate should be limited in if the colon is present, as the oxalate, most of the oxalate part is absorbed in the colon. So incidences of evidence of this says that this kind of patients have more of the renal stone. Fiber allow in moderation to the patient, especially with colon. Avoid high fiber diet for first few weeks after the surgery. Dietary recommendations are very individual and matter. This depends on the ostomate's body. Every kind of diet here we whatever we are I'm saying ki this kind of fluid should be allowed to this patient and this kind of carbohydrate should be allowed to this patient. But every ostomate body is individual. We should design the diet for individual according to their need and according to their surgery type, according to their remaining anatomy. Different food and drink may disagree with one person, but may have no effect on someone else. Ostomate should eat a variety of food, well-balanced diet with fruits and vegetables. Small frequent meals should be allowed and considered. Chew well, food properly, especially ileostomy patient. Use trial and error method to determine food tolerance level. Even after all these things in track, some ostomate may need partial nutrition and fluid in addition. So here are some lists. Food that thickens the stool. Refined flour, bread, some of the bakery products, rice, banana, butter, sago. This solidify this stool consistency so that stomach output can be controlled and bulk can be created. Food that causes stomach blockage. Fruit peels, छिलके वाली सब्जियां, छिलके वाली दालें, dry fruits, nuts, coconuts, popcorn, etc. That contains the high roughage, kind of high fiber. So food that lightens the stool. Raw fruits and vegetable without seed and without chilka. Oily and spicy food, green leafy vegetable, alcoholic beverages, whole grains. Food that product excessive gas or that contains lots of this alcohol, carbonated drinks, egg, fish, cabbage, onion, garlic, and green leafy vegetable. So these are the lists which need to be designed according to the stomach output and then this short bowel remaining gut. Thank you for patiently listening.